evening to everyone. I'm Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this next edition of No Thrombosis. So this must be our 45th edition of No Thrombosis. So today we have connected with 4 new cases and a lot of discussion. And it gives me a pride, privilege and honor to welcome our course director, Dr. M.S. Hiremat sir. And it is sir's enthusiasm and sir's drive which making this program really successful. So sir is a director at Cath Lab at Ruby Hall Clinic, Pune in India. Sir has been a past president of CSI 2017 and convener for the National Interventional Council of India of CSI from 2004 to 2006. Sir had proctored many interventional cardiologists and has given many live courses across the globe. Though sir is a coronary interventionist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. And sir has been a part of many groundbreaking trials. And it's indeed a privilege to have sir every monthly and to discuss a lot of cases and his own cases. That's really encouraging. At the same time, I take in a privilege and honor to welcome our course moderator, Dr. Gaurav Verma. It is again a nostalgic feeling for me when we started this program almost 2 years or more than 2 years back on 14th August 2020. So Dr. Gaurav Verma was the first case presenter for this program, and he could see and witness how the progress of this program. And I'm really glad and very happy to welcome Dr. Gaurav Verma sir as a course moderator and discussing his own case and bringing a lot of discussions and pearls of wisdom with discussion with other faculty. Dr. Gaurav Verma is a senior consultant and interventional cardiologist and associated with SMBT Hospital, Nashik, and Tambe Hospital in Sangamner, which is close to Nashik. He has performed more than 10,000 coronary angioplasties, including femoral and radial and brachial, and completed more than 2,500 BMVs. Done around 1,500 congenital procedures, including device closure of BAV and BPV. And he has been a recipient of prestigious RC Gold Medal for outstanding performance during MD examination, awarded by Devi Ahilya University, Indore. And he has been many articles on his credit published in a national and international journal. Now, I wish and happy to welcome our speaker for the day and the case presenter for the day. Our first case presenter is Dr. Varsha Kiran. He is a consultant and interventional cardiologist at Apollo Hospital, Jubilee Hills, Hyderabad. Incidentally, our moderator who has been associated for this program a long time, Dr. A. Srinivas Kumar sir, on the same institute he belongs, and he has won many awards, including JCM Shastri Memorial Prize in 2012, Gwenda Levis Prize, and Philip Korula Medal. He has also been author for several publications in national and international journal. Our second faculty and the case presenter for the day is Dr. Ravindra Dev. He is a clinical and interventional cardiologist at KIMS Icon Hospital, Visakhapatnam. He has more than 20 articles published in a national newspaper and participated in many national and international conferences and more than book chapters on his credit. He will be presenting a case of intra-procedural stent thrombosis. And interestingly, our two faculty, Dr. Gaurav Verma and Dr. M.S. Hiremat sir, will also present their own interesting case. So this would be our case presentation, first by Dr. Ravindra, case of intraprocedural stent thrombosis, followed by Dr. Varsha Kiran, ostial left main CTO recanalization by Rendezvous technique. And this would be our agenda. With this short note, I will stop here and maybe we can have an opening comments from Dr. Gaurav Verma, and Dr. MSS sir is in the procedure and he will be joining in maybe in 10 to 15 minutes. Our second moderator, Dr. D. Ramesh sir, is quite busy in upcoming CSI. We all know CSI is in coming month, and there are a lot of meetings are going on. So he personally requested, and he would be excused from this program, and we will join, and he will join in the next program. So I will stop here and hand over this session to Dr. Verma to take this forward.
Thanks, Omkar, for your kind introduction. And hello to Varsha and Ravindra. Hi. And hello, everyone. We are here to, present cases. Each of us will be presenting and sharing our knowledge. And as Omkar has already, told about the basic outline of the program, and I have been associated with this for last 2 years. And there are different subsets of no thrombosis program. One is about intervention. This is about basically a hardcore interventional forum in which we share our cases and then discuss the complexities, the complications, the how do we get out of that. And some of the mentors are there who teaches us and guides us how we can improve our skills. So, continuing with that, we will be having 4 presentations, 2 with from my co-speakers and 1 with our legendary Hiramet sir. So, starting with that, let us invite Dr. Varsha is going to present first, is it?
I'm
Sure. Varsha, go ahead. If you are ready, then we can start with your presentation first.
Yeah.
You can just share your screen.
Yeah, my slides on?
Yes.
Yeah, visible.
Yeah, good evening, everyone. I think, and thank you for creating this opportunity. I think in the midst of a huge surge of webinars and webinar fatigue, I think this is a good and interesting topic for everybody's benefit. So I'll be taking through this very interesting case that we had encountered last year. So it's essentially a lady with a left main ostial CTO, which by itself is an extremely rare thing. And we ended up doing it using the rendezvous technique, which is classically described in a lot of peripheral interventions. So at the outset, I declare no conflicts of interest, and going right to the case, it's a 66-year-old lady who's a hypertensive, had admitted during the peak of COVID pandemic sometime in May or June of 2021 with a severe COVID pneumonia. At that time, the CT severity score was 18/25. And she was on non-invasive ventilation. She was on BiPAP at that time. And on day 4 of hospitalization, the patient complained of chest pain, at which time the troponin had risen from 540 to 721. The LV systolic function was normal. So that is when we were called in. And this was the ECG at the time of our intervening. So as you can see, the 12-lead ECG showing a sinus tachycardia and a diffuse STT depression in the infralateral leads with ST elevation in AVR and lead V1. So at that time, patient had normal LV function and the pain had settled with NTG infusion. So a conscious call was made that, okay, since the patient has improved with conservative care, we will wait for 14 days, wait it out the COVID infective period, and then take her up for a coronary angiogram. However, we did sound out the option of, in case the patient deteriorates, we are ready to take her up for an immediate procedure at any time. So thankfully, the patient kind of improved, the oxygenation improved, and she got better, and she got shifted to a room, at which time we had taken up for a coronary angiogram. I'm just playing the intervention pictures because they were much better taken. So as you can see, the panel on the left showing a left-sided selective injection, non-selective injection, which is showing kind of a bald, stumpless occlusion of the left main. You don't see any filling of the LED or the LCX. Whereas the panel on the right, you can see a selective right coronary injection, which was a superdominant right coronary artery, which is giving render of grade 3 collaterals to LED and LCX. And you can also see a significant portion of the left main, which is filling. So essentially, we were left with a patient with persistent dependence on oxygen. So at that time, the surgeons were unwilling to take her up for CABG. And unfortunately, 2 days later, patient developed a large rectus sheath hematoma while on Clexane. Her hemoglobin had dropped to 4 grams. we needed to transfuse 4 units of blood and had to stop all blood thinners. So she was on dual antiplatelets and Clexane, which had to be terminated. And after correcting the hemoglobin, her breathlessness improved. And eventually, after 21 days, she got discharged on beta blockers, nitrates, and renolazine. We had not reinitiated any blood thinners at that time. So she remained symptomatic on maximal anti-anginals, and we started a single antiplatelet after a month. A repeat ultrasound showed significant reduction in hematoma, so we restarted dual antiplatelets eventually. So at that time, a conscious call was we would revascularize a month a month later if the dual antiplatelets are tolerated and no further hematoma occurs. Unfortunately, this was her HRCT at follow-up almost 2 to 3 months after her illness. As you can see, there is bilateral lung fibrosis, and patient was dependent on oxygen at home, and with minimal exertion, even walking to the washroom would desaturate her, and she was essentially homebound. So despite having a stable hemoglobin on antiplatelets and echo showing normal LV function, because of the persistent lung fibrosis, the surgeon was unwilling to take her up for a bypass surgery. So at that time, we reinitiated the discussion about percutaneous intervention. So both an option of antigrade versus retrograde had to be considered. So as you can see, our first preference was to try and do an antigrade crossover. So the panel on the left shows a Fielder XT-A wire. Unfortunately, there was no leading stump for us to even engage the wire to cross. So we were essentially unsuccessful in navigating antigradely at that time. So we decided to switch our strategy to retrograde wiring. So as you can see, the panel on the left, we got a microcatheter which has engaged the collateral of choice. And through that, we had taken a cyan blue wire by collateral surfing, and we have ended up in the proximal LAD segment, as you can see in the panel on the right side. So at that time, we actually reconsidered an antigrade wiring just to make our procedure much simpler. So the options that we were left were with either retrograde tracking of the microcatheter and exchange for a stiffer wire, maybe take the same Fielder XT wire or maybe upgrade it to a Gaia, or maybe an antigrade attempt and try to rendezvous the two wires. The reason we actually went ahead with doing the antigrade attempt was because the left main stenosis was, left main occluded segment was extremely short, as seen in the first injection. So as you can see the panel on the left, you got a Gaia wire which has retrogradely come through the collateral channel, which has almost reached the tip of the left main, telling us that the ostial left main occlusion was a very short segment. So at that stage, we actually escalated a wire. We changed the Fielder to a Gaia 2 wire. And you can see the Gaia had penetrated the occluded CTO segment and reached the LAD, which was confirmed in an antigrade injection. And then following that, we did a balloon angioplasty using a 2 mm balloon into the left main to LAD, following which we could wire the circumflex as well. So we had 2 cyan blue wires, one in LAD and one in circumflex. And this was the initial intravascular ultrasound done from the left main LAD backwards to the LAD, so to the left main. As you can see, focus here, that is the ostium of the left main, which was very critically narrowed. But of course, this is after the initial predilatation. So the landing zone, we got a luminal diameter of around 2.75 to 3 mm, and the left main area was diameter was around 3.5. So we decided to go ahead with a 3.5 stent and deploy it nominally, and then do a post dilatation at a higher size balloon in the left main alone. So this is a 3.5 to 15 mm Everlima saluting stent from left main to the LAD. We try to remain as small as possible. And immediate post-stent result was fairly satisfactory. There was some pinching of the left circumflex, but given the size of the vessel, it just was not worth doing anything to that. So we did a pot with a 4 mm non-compliant balloon. And this is the final angio for the day. As you can see, there was a TIMI3 flow. There was a minor step down, but no edge dissection, and brisk flow down the circumflex as well. And this is the final intravascular ultrasound done, which showed a good apposition and final left main area of almost 12 millimeters square, and a distal LED landing area of around 8 millimeters square. So essentially, there are a lot of pointers from this case. So it is well known that a left main occlusion often tends to be thrombotic when there is an acute coronary syndrome. A CTO of the ostium of the left main per se is extremely rare, and it's very often a non-atherosclerotic induced one, like in Takayasu arthritis or syphilis or rheumatoid arthritis. Radiation is another common cause for osteal left main involvement. It is dynamic compression of left main is seen in severe PAH, and usually the first line of management is surgical. There are quite a few things that really don't fit in our patient. The fact that the patient is elderly, she's 66-year-old, she other visceral arteries were clean, so vasculitis was seemingly unlikely. The inflammatory markers were unreliable because she had severe COVID pneumonia, at which time the CRP was high. And we did do a CT coronary angiogram prior to procedure, which showed isolated speck of calcium in the ostium of the left main, and the overall calcium score was only 14. So as you saw, the rest of the arteries were pretty free of atherosclerotic disease, so which also was not really fitting in with an isolated atherosclerotic lesion. So another oddity was the fact that the patient had normal LV systolic function despite a rise and drop to 700s, and she tolerated a sudden HB drop to 4.1 grams when she had a rectus sheath hematoma, which makes us think that it was a chronic occlusion with a well collateralized left circulation rather than an acute occlusion. So this rendezvous per se in coronary, it's just a modification of an antegrade retrograde tracking, was well described over 10 years ago. And a recent publication from India also exists, but this was done in a 27-year-old lady with a documented or diagnosed Takayasu arthritis. So essentially, an seemingly atherosclerotic left main osteal CTO per se is extremely rare. So I'd like to conclude by saying that the post-COVID lung fibrosis is very common and often poses a high risk for general anesthesia. And left main osteal CTO is very rare. An option of retrograde antegrade rendezvous can be considered. And IVUS optimization of left main stenting is must for better long-term outcome. Thank you.
Dr. Verma, Dr. M.S. Hiramat sir has joined. So, yeah. Good evening.
Hi, Dr. Goro, and hi, everybody.
Sir, could you see the case?
Yeah. I was there right from beginning. Yes.
So before we start, just let me say a few words. I'm really very happy and fortunate to have sir on board, and it's a great honor to moderate under sir's leadership. Sir is a Carlos, exemplary cardiologist, astute clinician, adept interventionist, and many of us are a student of sir. And on personal grounds, I idolize sir, and sir is like everything for me. I just hero worship him. So, sir, welcome, and please now we'll start with your first comments, and then we'll see.
Sir, before we start, sir, I just want to make one comment. Dr. M.S. Hiramat sir, Dr. Gaurav Verma sir was the first presenter for KT, maybe more than 2 years ago, and sir has now joined us today to present one case and to moderate this session. So we are really happy and we are really nostalgic, sir. 14th August 2020, he presented a first case and opened the KT forum. And with under your guidance and under your leadership, sir, we are tirelessly working, and it's a 45th edition, sir. Thank you so much. This is your keen interest, your enthusiasm, and your guidance making this program successful, sir.
Hey, Gaurav, whatever Dr. Omkar said, you deserve every bit of it. And we are really, really happy to have you here and your expertise. And you are somebody who has multiple thought processes working at the same time. So let me ask you, this case which was shown, would you have done this attempt retrograde, or you would have persisted on antegrade?
Sir, actually, first of all, the case done was excellent. Varsha, congratulations. But as sir said, antegrade should be the first choice, and definitely it's a blunt stump, it's a flush occlusion, but surely antegrade, because of the hardware and the type of catheters what we have. And what I got it from the angio that it was probably a thrombotic occlusion. It was not atherosclerotic, like you clearly said. And in a young patient with subset of COVID, probably it was a subacute thrombotic occlusion, which probably nobody could notice before. And I personally feel that antegradely we could have tried, catheters. And once we are finished with all the options, then I should have gone for the retrograde. Of course, retrograde was quite easier because you had a very good collaterals to go in. But sir, what's your comment?
The wire that you used when you went antigrade, I thought you used a Feeder XT, right? And Feeder XT crossed the lesion and...
No, finally, we actually had to change it to a Gaia.
Gaia 2.
Initially,
Gaia 2, right?
Gaia 2, yes. Feeder XT did not have enough penetrating force.
Feeder XT, I mean, it's a good wire, but I generally keep it for vessels which have a lot of bends and yet near CTO. So if you have a very hard ostial left main, I would probably choose something else. I mean, Feeder XT remains a good choice wire whenever you have a CTO very distal in the vessel. Here you had everything right at the ostium, so you need to have a chaku, and probably the Gaia 2 served a purpose. I love this wire Gaia 2. I mean, many people talk about Gaia 1, Gaia 2, and Gaia 3, but somehow Gaia 2 works every time Gaia 3 is expected to work. And I have sometimes gone back, like I taken Gaia 3, didn't work, and then I go to Gaia 2. My staff sometimes is surprised why I'm doing that, but it's just the feel that the Gaia 2 gives, and you also had a very quick and easy pass with Gaia 2. So I think it's a very good wire for proximal lesion.
Sir, if I ask here, suppose you don't have a Gaia wire available, then what would be your second choice?
I would still take a stiffer wire.
Maybe, do you prefer now CrossFit series or no?
No. I would take Conquest Pro.
Or Miracle?
I'm not very familiar with Miracle.
Exactly. This is, we are also, geared up for only Gaia, In such cases, Gaia is the only option. Second, doesn't come to my mind that what I should be having on board. So I just wanted to have your opinion.
No, I think you should keep 12. What is that wire?
Miracle.
Conquest Pro 12. And I think I told on this forum earlier that I had never used Conquest Pro 20, but I was doing a live from Dhaka, and the live, I don't know where it was getting transmitted, and in that CTO, the none of the other wires worked. So I asked for Conquest, and they gave me Conquest Pro 20. And I had never used that. So I told them, don't you have 12? So they said no. But then it worked. We had to be very careful, of course. And we were doing live from Dhaka. So I think I think that's how we learn. I mean, we are pushed into a situation, and cardiologists are very sticky and they never give up easily. So they try and do many things which are not necessarily written in the book or seen by them earlier. But that is how innovations come into place, and that is how somebody like Gaurav or Dr. Kiran can sort of, I mean, you're going to lead. I mean, one case is good enough to sort of set you thinking that next time you have a similar lesion, how would you approach? But, if the guide is sitting properly, I would definitely go antegrade in this case.
You also feel, sir, it would have been a thrombotic etiology, or you feel it's a...
I mean, this was a young case, young patient.
So just a correction, the lady is 66-year-old.
Oh, I thought
it's not 27.
No, 27 was the case report that I showed you,
okay,
which was not fitting in with ours.
So if he's 67 still, then this Takayasu is out of question, isn't it?
Yes, exactly.
I
And
mean,
also when the patient had a retroperitoneal, the rectus sheath hematoma, we got a CT aortogram, which would have picked up visceral artery lesions had they been there. So
You're right.
if the other vessels are all clean, like your RC
Yes.
was brilliant, huge normal artery, and it gave retrograde so beautifully to the left side, and there were no other lesions. I would probably think this is not a typical atherosclerosis, and approach it with a stiffer wire. But everything that you did was absolutely perfect, including the good ostial stent position. I'm going to show in the end one missed left main ostium. So which are the views you take to make sure that you are in a good left main ostial position? Which views?
I usually do a plain PA and a iliocranial before deploying it.
Plain PA and
Iliocranial, the hepatoclavicular 45-15 ilio and cranial.
Yeah, I mean, I'm probably a little bit more LAO, 30-30 or maybe 30 and 45 LAO, 45 cranial, 30 LAO and 45 cranial. But anyway, this is a very good view, and double check in some other view too. I mean, left main is one such area where I think you can't have, I mean, nobody would pardon you. And even the disaster is so serious that you have to spend time searching for the perfect left main ostial.
Sir, just
Even if it projects out into the aorta, in fact, there are people who intentionally put a strut outside into the aorta. I think it's still a good option. That gives you a very good option of having some metal at the ostium. Part of the balloon floats out, and with a bigger diameter balloon like 4.5 or 5, you hang the balloon in the aorta and go high on pressure. Yeah, Guru, you were saying
yes,
something?
sir. So this is what you just said regarding the placing of the stent. Now people say that left main ostium is more oval than circular, and iliocranial will tell you more about the upper part of the left main, the upper edge where you have to place the stent. So like you said that we need to keep a stud outside. But some people say no, we have to just be at the ostium, because if we keep outside, the next time the catheter, if you want to cannulate, that becomes very much riskier if there is restenosis. So what are your thoughts?
No, if you keep it outside, there is no next time. The patient will continue to do well. If you miss the ostium, patient will definitely come back. So I would definitely make it a point to stick out the stent a bit.
Fine.
I mean, we all say that whatever lesion we want to stent, you must have a little bit of metal on either side of the lesion. So same holds true in this kind of situation.
Not for this case, sir. So this is clear cut. You have to be outside because you can't miss ostium. Suppose it's a distal left main and ostial is clean. So will your strategy change, or will you have to keep outside only slightly?
Well, if there is nothing at the ostium as judged by angiogram or even imaging with OCT and IVUS, probably, I mean, I used to not come back to the ostium. Sometimes the left main is long, like say 30 millimeter left main, and you are stenting a important vessel long just for nothing. I mean, there's no lesion. You have a lesion just at the distality. So I would probably, but I'm a little bit liberal about the length in the left main.
Sure. And one more question, sir, regarding the choice.
If I may also add a point, I'm so sorry to interrupt. If I may also add a point to that same question, I think to keep things very simple, the way I would probably look at whether to cover shaft of the left main or proximal left main is, I would want sufficient length for my pot balloon. So if just the distal left main is deceased, I would leave sufficient length of the stent in my left main so that I can do a good pot, because invariably there will be a size disparity, diameter disparity between the left main and the LED or LCX. So if it's a short left main, let's say 10 to 15 mm, I would probably cover off the ostium so that I'm sure that end of pot I'm not doing an edge dissection. But like sir said, if it's a long left main, I would still have sufficient length for a good pot. So at least 10 to 12 mm I would want in the left main.
Varsha, if this is just a 6 millimeter left main, what do you do then for pod?
Then I can obviously overhang the balloon. It's not going to harm it, right? So,
Right.
You mean float the balloon in the aorta and go high pressure? Is that correct?
yes.
Or otherwise, what people advocate is a step pod. That you go to the ostium with a smaller balloon and then just come out, gradually, keeping inside the length with a less pressures or higher balloon. That way you can do. There is a smaller size balloon at the ostium at the distal, and then a bigger balloon but less pressure till the full length. You can do that way as well.
No, I didn't understand, Gaurav. What
Sir,
did you?
suppose the left main length is just 6 millimeter, and you have chosen from left main to LED you have put a stand of 3.5, and the LED you want to do pot with a 4. Then they recommend that with a 3.5 you do a high pressure pot till the ostium of the LED and just part of the left main, and the rest you can choose a 4 balloon but at a lower pressure. You don't have to go too high, maybe 8 or 10. If LED,
Oh, that 4O balloon is in left main or in LED?
yes, for the actual left main, because we need to capture the ostium more importantly. So for left main, for the LED ostium, you go at a higher pressure but with the size of the balloon of LED size. And for the rest part of the left main, you take a bigger balloon but don't go to a very high pressure for the risk for rupture.
I mean, basically what you're trying to say is highlighting the high pressure.
Right.
So instead of going high pressure on 4O balloon, it's better to go high pressure on 3.5 balloon.
Exactly.
Yeah, I think a lot will also depend on what kind of wall you're dealing with, If the wall has no calcium, I think what you're saying will work very well.
Sir, one more question. Any preference for the type of stent if you are taking a dedicated bifurcation stenting for left main? Do you prefer some stent particularly?
Yeah, Dr. Omkar, this kind of questions are never discussed in angioplasters meeting.
Yes, sir.
But
Yes, sir.
this is a special invitation from Emcure, so we can discuss the truthfulness. Let's ask Gaurav himself. What is your choice?
Sir, when I'm doing a bifurcation, especially left main, I require strength because I have to do pot. So for me, Zeiss, scores over, this Medtronic stent. Synergy, I don't have much experience.
But the Zeiss, the maximum diameter available is 4.
Sir.
While both Medtronic as well as
Synergy,
they have 4.5 and 5. So I'm never very fond of taking a 3.5 to 5.5. Not my style. So I go about 0.5 or max 1 more than the stent diameter. So the stent diameter, it shouldn't really matter because stent has no diameters. Stent diameter is the balloon diameter basically. So same stent put on a 5O balloon and a 4O balloon, and the outside label will be 5O and 4O, but basically you and I know that the stent can be stretched. However, I'm not very fond of taking a 4O balloon to 5.5, So I think the designs are also different in some of the stents, so we must respect why the design is different. And we don't want the studs to move away from each other.
Sir, I don't know whether the Synergy Megatron has come into India because they have just launched a big size stent. Have you experience, sir?
No, I don't think it's in India.
It's not yet come. So if there's a 5.0 left main and a 3.5 and 3.5 LED circ, you will take Onyx, is it? You prefer Onyx?
I love Onyx, yes.
Fine.
But yeah, I mean, Onyx is also there in 4.5 and 5.0. So we use it in left main sometimes.
Fine. Sir, if you permit, we'll move forward, sir.
Oh, yes, sure.
Yes. So thank you, Varsha. It's excellent case, excellent learning. Probably we'll try to do more retrogrades. We are not that much, well versed with doing retrogrades because the hardware requirement and the type of people what we serve, don't pay too much. But
So
it was a great case.
when I presented this in TCT, the moderator's comment was, wait till you do your 100th retrograde case. You would have not even attempted antigrade. So,
Yeah, of course.
so I guess it's
I agree.
definitely a matter of.
No, but it requires courage, to go for retrograde. And really, you should have everything.
I think the learning point was, although we were gearing up for going retrograde since our initial antigrade attempt failed, it was the fact that we went back, persisted on trying an antigrade attempt, which actually eased out the procedure. Because had I ended up going retrogradely across the lesion, I would have still had to snare it. There are a lot of steps left. So I think we eased out the procedure by re-attempting an antigrade puncture with a fluoro marking. The retrograde wire served as a fluoro marker for our antigrade puncture.
Fine. Great, Varshal. Thank you. Let us invite Dr. Ravinder Dev. Ravinder, are you ready?
Yes, sir, I am ready.
Yes, please go on.
Good evening, everyone. Firstly, I would like to thank all my senior doctors for giving me this opportunity. I would like to present two short cases. First case is a case of intraprocedural stent thrombosis. A 64-year-old male, hypertensive, presented with complaints of chest pain since 3 days. ECG showed T-wave inversions in lead 3. Troponin I was positive. Echo showed inferior and posterior wall hypokinesia with LV function of 50%. And CAG was done. So CAG showed proximal LCX 80% stenosis with thrombus. Distal LCX was thin and diseased. Proximal to mid LAD had 70% stenosis. RCA was a thin vessel with distal RCA 80% stenosis. So he was planned for PTCA to LCX and LAD. So LAD, LCX were crossed using Renato guide wire. L6 lesion was predilated with 2 into 12 mm semi-compliant balloon. Later, 2.75 into 28 mm stent was deployed from proximal L6 to major OM. Post dilatation was done using 2.75 12 mm non-compliant balloon. Good result was achieved in the LCX. Then after pre-dilatation of the LAD lesion, LAD was also stented using 2.75 into 36 mm stent. Post-dilatation of LAD was done using 2.75 into 12 mm non-compliant balloon. At this time, patient developed chest pain. ECG showed ST elevations. Patient developed bradycardia and hypotension. CINI was done, which showed a very slow flow in L6 with a lot of thrombus. This was the CINI after the LAD stenting. So immediately a 2.75 into 12 mm balloon was passed into the L6 until the distal part of the major OM. Atropine was given and inotropes were started. ACT was checked, which was adequate. TIMI 2 flow was achieved after passing the balloon. So patient chest pain decreased and blood pressure and heart rate improved. Intracoronary NTG and tirofiban was given, followed by infusion. Intracoronary nicorandil was also given. So again, post-dilatation was done using 2.75 12 mm non-compliant balloon at high pressures. Then CINI showed TIMI 3 flow in the LCX. But there was migration of the thrombus into the distal LAD. So in this CINI, there was a thrombus present in the distal LAD. So again, 2 into 12 mm balloon was passed till the distal LAD, which cleared the thrombus. The final cine showed good flow in the L6 and LAD with no residual thrombus. So coming to discussion, factors favoring thrombus formation during PCAR, triggering of the plaque in the thrombus with the guide wire, balloon or the stent, the so-called angry clot phenomenon, inadequate anticoagulation, poor stent apposition to the vessel wall, lack of or premature or abrupt cessation of the thienopyridines, hypercoagulable state, heparin-induced thrombocytopenia and thrombosis, vasculitis, increased WBC count, hyperglycemia and cocaine. In this case, we thought either poor stent apposition to the vessel wall or angry clot phenomenon to be the cause for the stent thrombosis.
Tell us a little bit more about this angry clot.
The lesion is more thrombogenic, sir, when we try to pass the lesion using the guide wire or the balloon. It may stimulate increased thrombus formation. Even the guide wire or the balloon or the stent can also aggravate this.
So you can't pre-diagnose whether the clot is angry or not angry. No. I mean, are there any look of the clot which tells you that this is an angry clot? No.
No.
All right, let's go ahead.
Okay. So coming to management, whenever there is an abrupt closure of the vessel, the differential diagnosis should be either dissection, thrombus, spasm, air embolism, or neuroflow phenomenon. Or if it is in the side branches, then it may be due to plaque shift. When this occurs, recheck ACT and give intracoronary nitroglycerin. Repeat the angiogram and IVUS or OCT. In this case, imaging could not be done due to financial concerns.
How much was your ACT? You told us it was adequate, but how much was it?
302, sir.
Oh, that's good.
Then, in this case, the cause of the abrupt closure was thrombus, and what we can do was either thrombectomy using a thrombosuction catheter, giving a GP2B3A inhibitor, and if we confirm using an IVUS or OCT under expansion of the stent, aggressive redilatation, and optimizing the antiplatelet therapy. And we can give a distal delivery of the vasodilators also. So what I learned from this case was keep the guide wire in the vessel until the end of the procedure and establish flow as soon as possible in case of intra-procedural stent thrombosis.
In fact, I was going to ask you, you had a wire in LAD and wire in the circumflex OM.
Yes.
In all your pictures, we could see two wires.
Yes.
When you're doing circumflex, you had a wire in LAD. Is it correct?
Yes, sir. Yes, sir.
So that is your style? You always do that? Have wires in two vessels at the same time?
Not always, sir. But in this case, we are planning for stenting of both the vessels, sir.
It doesn't matter. I mean, you would think of, no, why don't you finish one, like finish circumflex in this case, which was your first vessel. Put the same wire in LAD after circumflex is over. I mean, if your stent is going to be a V kind of stenting, the back end of the stent is going to touch each other, I would wire, predilate, and probably deploy the stent at the same time. But generally, most of the operators I've seen, they finish one vessel, put the same vessel in the second branch. I mean, taking two wires just for a routine case, probably not necessary. If you're dealing with sort of V stenting, that is the only time I think I take two wires at the same time. All right, let's go ahead. You have one more case, right?
Yes, sir. Yes. So second case is a case of STEMI in split origination of left coronary artery. A 49-year-old male diabetic presented with complaints of chest pain since 2 days. ECG was suggestive of evolved anterior wall MI. Echo showed anterior wall hypokinesia with moderate LV dysfunction. CAG was done. The initial CAG showed as it looked like an ostial LAD total occlusion with mid and distal LAD retrogradely filling from the LCX. The cranial view also showed total occlusion of the LAD. But a closer look in the caudal view showed a separate origin of LAD above the LCX. So in this caudal view, there are retrograde filling was coming into the aorta just above the LCX. So then LAD was selectively engaged, which showed proximal LAD total occlusion. So cranial view nicely demonstrated the proximal LAD occlusion with faint antegrade flow. So he also had a mid-RCA critical stenosis, and he was planned for PTCA to LAD and RCA. So LAD was engaged using an XB side hole catheter. So lesion was crossed using the Renato guide wire, but the wire went into the diagonal. So another wire was passed into the LAD using a 1.2 balloon support. So lesion was predilated using a 2 into 12 mm semi-compliant balloon. After predilatation, angio showed good flow in the LAD. So a 2.5 into 48 mm stent was deployed. Post dilatation was done. The final cine showed a good result in the LAD.
The stent was coming back to the left main ostium.
Yes, sir.
45 length stent was coming back to left main ostium.
To the aorta, sir. There was no left main in this case.
It was only LAD.
It was a split origin, sir. Only LAD was coming separately, sir. We stented from the ostium, sir. Just one strut into the aorta.
Okay. But there was no ostial disease in this LAD, isn't it?
No,
I mean, you could
no
have
ostial disease. There was stump. Stump was there.
Why you didn't stent only the narrowed portion of the LAD? I mean, you use really a long stent, isn't it?
Yes, sir. The tapering was there till the distal LAD, sir. So we have to take a long stent. And there was only 5 to 6 mm stump from the aorta, sir. And the lesion was also very thrombogenic. It was an acute coronary syndrome. So we thought as there was LCX is also arising separately, there was no risk covering the ostium also.
All right, let's go ahead.
That's all, sir. Thank you, sir.
So, Gaurav, any comments from
Yes,
your side?
sir. I was waiting for the first case, sir. I have two, observations. One, his ACT was okay, 300 plus. So probably heparin was not the culprit. Second thing, what was the antiplatelet, Ravinder, did you use?
We are using ticagrelor and
So
ecosprin.
that is also perfect. Probably that was not the issue. Then only thing which comes to my mind was probably it was thrombus which are generated inside the catheter. Probably if you are dilating for a longer time, longer duration of there is some crisscross of the wire, then sometimes we have seen that catheter gets inside the catheter, and when you push angio and then that goes into the circumflex. Sir, what do you feel? Because heparin wise and antiplatelet wise it was okay, and there's no as such a lesion which should be highly thrombogenic, what I could see. Ravinder, what's your opinion for that? What do you feel? What was your thought process for the origin of this thing,
My
thrombus?
thought process was stent.
apart from, you mentioned about 10 points as a possibility. The other thing which comes to my mind is heparin resistance. And it is generally never discussed. It doesn't even come to our mind that heparin can have a resistance. But generally, people who have received, like they are in CCU for 5 days in another hospital, then they transfer. And these are the cases where I would feel heparin resistance is something which we should probably keep it in mind. But you checked ACT and it was 302. So probably that was not there.
Sir, regarding the second case, sir, just want to take your opinion for longer stents. Your strategy is two small stents or one long and then you do pod?
So based on the proximal and distal diameters, sir. If there is a greater mismatch, I will take 2 stents, sir.
No, because yours was CTO, so you cannot actually estimate what the diameter of the vessel, isn't it? So,
Sir, it was an ACS, sir, acute coronary.
Okay, it's a ACS.
Anterior wall MIS.
Fine. So, did you do a proximal part with the proximal part, or you didn't?
Yes, the post dilatation was done until the ostium, sir.
Fine, nice. Sir, if there are no more discussion, can we move ahead, sir?
I just have one more, since I just wanted sir's opinion and yours on the role of non-culprit PCI in this kind of setting. Like, I think that's a very hot topic of debate, and different people have different strategies within the same institute. So,
sir, your comments? Probably, Varsha. Sir.
Kiran, what was the?
So my question was your strategy with non-culprit PCI in a setting of a STEMI. How would you approach, or what would the ideal time be?
Honestly, I used to stay and do it the second vessel at a later date, say 2 days or 3 days later. But I think sometimes the lesion is so simple that the non-culprit lesion is so simple that you feel like doing it. And that's how I, these days, try and finish everything in one go. Though you can show yours, not a problem.
Whatever you say, sir.
Okay, I will show.
Yours.
Pehle aap ho raha hai idhar. So this was a young gentleman. He was in mid-50s. I'm calling him young because I'm at 70 now. So he presented with ACS, and there was a left thrombus. He aspirated, the flow looked much better. We gave tirofiban, and we stented this area with 4.512. The stent ended before the distality of left main. That means it was the ostium and proximal portion. And then this was our doubt if we had missed the ostium while stenting, especially when we were bringing in a balloon. We were bringing a guide catheter in and out to get the balloon in. We probably felt that the stent got pushed in because of the tip of the guide catheter. 1 month later, a disaster happened. This patient came with an acute presentation, shock. So we had to put in IBP, and then I will show you what was the narrowing. So this was the case. He had ST changes, which were all over, inferior as well as anterolateral leads. and the presentation was within 3 hours. The coronary angiogram, which you're seeing, is done on day 2, and you can see a thrombus in the left main portion. The flows in LAD as well as circumflex don't look bad, but this was a very important location, and we sort of were thinking whether to do angioplasty at that time, or there was flow, so put him on maybe GP blockers, heparin, and bring him back the next time. So there are some other pictures of the left main. Somebody might even think that it is a catheter tip dissection. I just thinking loudly. So many times the fellows, they take pictures and you see this kind of situation. Just be aware of this kind of catheter-induced dissection of the left main. So we decided, should we do intracoronary lysis since we're right there? And these are some of our cases where we have taken patients for PAMI. This was an inferior infarct at 12 hours presentation. We did primary angioplasty, but obviously there were thrombus on the vessel, and the final result on day 1 definitely is not a happy result. So we bring him back on day 2. He received tirofiban and heparin in this 24 hours period, and the flow looks better. So you can see a clear difference between day 1 and day 2. And that's the time we had a small stent. This was another case where there is a thrombotic occlusion, thrombotic narrowing, so to say, in the left main area. And this patient, they were not sure whether they want an angioplasty or they wanted to manage this case medically. So we gave, and this was in a peripheral lab, so we gave intracoronary urokinase, and a day later, we did an angio and an angioplasty. This was a non-STEMI. A patient was stable after initial tirofiban and heparin. So no pain for 24 hours, and then the angiogram is done. And you can see the orchial left main is showing a very critical disease. These are the cases. You try to take them off the CAT table and they would have a sudden death. So we discussed with the family, and we did a cutting balloon dilatation. Somebody would have thought of rota too, but this was a thrombotic kind of lesion, and we did cutting balloon and stenting. This was another case, distality of the left main, as well as the circumflex osseum show critical disease. And one of my colleagues sent this patient for a bypass surgery, which I think is a reasonable decision. So this is back to our case. Some people suggested get his pressure up, maintain good flow, so why not put IABP? But pressure was not bad, something like 120, 125. Finally, after a lot of discussion, that is one good thing about Ruby Hall, that a lot of equal-minded colleagues are around and you can talk to them. So this was, we said we'll aspirate. And we have, actually, you can see the guide catheter tip is very close to the thrombus. So the thought was to wire one of the vessels and then with the guide catheter itself aspirate. It's a big bore and the catheter is sitting just at the tip. So I'm sure some thrombus would come out. There are other times when we have aspirated with guide catheter. And this was one such case. This was a post-bypass admitted with ST elevation. I'm sorry, the movies are not running in this. Oh yes, they're running. So this patient was thrombolized and was also given GP blocker. And this was the vein graft on day 2. Now you can see so much of thrombus is still persistent. And so what we did is this guide catheter was slipped into the vein graft all the way down, close to the junction. There was a balloon and a wire, and the guide catheter was slipped on top of the inflated balloon. So it went down and we aspirated the entire length of the vein graft thrombus. And with some kind of GP blockers, some balloon dilatation, we could see such a beautiful vein grafts. So this is purely a thrombus. We didn't need a stent in this case. And whatever we did was good that day. This is back to our case. We started working on him, and we gave him a thrombus aspiration with a thrombosuction catheter. Also gave intracoronary tirofiban, and the thrombus looked a shade better than what it was, but still in the LAO-cranial view, you can see a very ugly thrombus. And I'm sure most of you wouldn't leave this patient as it is for the fear that there could be a major serious emergency anytime soon. So after multiple aspiration, the thrombus looks a shade better than what it was. So we thought we will stop and check after 48 hours. After 48 hours, we had this kind of image, and we thought we would do a cutting balloon dilatation and do a direct stenting. I mean, the length was just about 15 before it bifurcates, so we thought we'll take a 12 millimeter balloon. Now this, I want you all to appreciate that when you are wanting to stent the ostium, this view, LAO cranial, it's about 30 degrees LAO and about 30 to 40 degrees cranial. And you can see the ostium of LAD very well. Keep your guide catheter slightly outside the ostium, and you can see the stent is very well placed at this position. And we inflate, and I don't know if some of you saw the stent seem to get pushed into the left main with the position of the guide catheter. So I would open up the ring at the back, the Y connection ring, before we inflate. And here I feel the stent got pushed in a bit by the presence of guide catheter just at the balloon mouth. And these are the pictures. You can see this is, of course, a stent boost, but you can see the stent is at least 2 millimeters away from the ostium. I mean, we had planned to actually get the ostium correct, maybe into the aorta, but when we saw this, we didn't like it at all. You can see the blue is the edge of the coronary, aorta, and origin, and the stent starts a millimeter or two inside the ostium. So this is a spider view, which looks, I mean, the ostium of the left main looks very good. So we were not sure whether we need to do something more or wait and watch. So we, these are the two views at the same time. This is an eleocranial view. And to me, eleocranial is a better view to get the ostium correct. And you can see the stent originates at least 2 millimeters inside. I probably feel that the stent got pushed in by the presence of guide catheter. So I'm always telling my fellows that when you are inflating, the Y connection should be loose so that the guide catheter get pushed in and not the stent. So in eleocaudal, it looks brilliant, but here you can see the stent is placed a little bit inside the ostium. So this is actually a stent boost, and trying to check on, in our lab, we have a stent boost and we can inject two, and it's a contrast stent boost where you can see the origin of the guide catheter and origin of the vessel. And we realized that we had missed the ostium. We were sort of hoping that, I mean, we waited for quite a while, thinking whether to put in another stent at the ostium and so on. But overall, the flows look good, and we shifted the patient to CU. This was Onyx stent. Onyx is now available in big diameter 4.5 and 5.0. And I want you to see the difference between eleocaudal here and eleocranial here. Eleocaudal looks brilliant, but eleocranial shows that the ostium is not covered by the stent. What do we do? I mean, we have missed it, so put one more stent. We thought we'll wait. And post, the other thought was post-dilate the stent, which we did. And a patient was sent home 1 month later. He presented with chest pain. He was stable at discharge. ECGs were reasonable. And he was taking Trecaglor and aspirin. 1 month later, he had severe chest pain. ECG shows gross ST, depressions in all the leads. And he was just rushed to cath lab. And you can see the distality of the stent is showing a presence of thrombus. The thrombus is extending into proximal LAD and ostial circumflex also. So from left main lesion, we are now into left main plus LAD plus LCX ostium. So trifurcation issue, not of course a happy situation. And the patient was taking all his tablets very well. So it was not a thrombus related to antiplatelet issue. And now this is something which I like to show as I thought I learned from this case. This was in peripheral hospital, and when we injected in left main, there is a critical lesion in left main with no flow. I mean, the flow is yes, no in LAD. In these kind of situation, best is not to worry about circumflex, but get a stent in. So we put a stent here from left main to LAD, and we had this kind of result. Fortunately, the circumflex is also flowing beautifully, and you can see the heart rate has improved, contraction also is looking brilliant. So we clearly saved something very disastrous which could have happened if we had not done anything at this stage. So our patient was put on IBP, and he was on tricaglor and aspirin. This is how the patient has presented with all the clots, and patient was put on IVP. This is 1 month after the original angioplasty. Tricaglor was changed to prasugrel, which this is something which I do very often, change the antiplatelet molecule. So we have 2 wires now, LAD and circumflex OM, and the flows improve after some intracoronary diaphragm. And what do we do at this stage? We do stenting again. See, this gentleman has a stent only in the left main, and he has come with thrombus on either side. So we decided to put in a stent, and this is a view I take to position the ostium. Dr. Just now we talked about the ostial position, and Dr. Deepak was saying Dr. Kiran was saying the location of the ostial position has to be very good. So this shows that we are not truly at the ostium. So we adjust and then decide we'll inflate. So this is a stent going on inflation. You can see the guide catheter moving away. So I like to keep the O-ring open at this time so that the stent and the guide catheter don't interact. After doing that, this is the 4.5 NC high pressure balloon. And this is a stent boost. And this I do very often. I mean, the balloon is still there. Guide catheter has been taken back for whatever reason. But while getting it in, while the balloon is there, I get it in so that you don't hurt the back end of the stent as the guide catheter comes in. It is over the balloon, so it will slide in nicely. So this is a long stent, and you can see ostium of the left main is well covered. And you can see both these views. The ostium looks very good. And this is the final result. So to summarize, this was the first presentation. A short stent was placed 4.512, left main before, and stent ended before bifurcation. But we were doubtful that we missed the ostium. The patient presented 1 month later with this kind of thrombus, and we had to put in one more stent from left main ostium towards LAD. And luckily for us, everything is good. All vessels are flowing brilliantly. It was a very, very important left circulation, as you can see on the angiogram. So missing left main ostium when you do left main stenting is really not a pardonable sort of offense. You must always get the ostium correct in different positions. So thank you indeed. I hope you like the case. Gaurav, any comments?
Sir, there are two things. First was probably the first event, first the plasty what you did was absolutely perfect. Definitely you missed ostium, but there was no as such aberrant obvious dissection, or there was something which you were missing. And probably sometimes we do find such cases. Leave at that moment. What you did was absolutely okay. What I felt was probably patient was having some prothrombotic condition which led to that, and probably
Or resistance to
oh yes, resistance to
antiplatelet.
ticagrelor. Third thing, with the availability of rivaroxaban, do you think that with this thing ticagrelor, aspirin, and there's a role of 2.5 BD rivaroxaban in such cases where you fear that if there's some you have left something, some ostium, and patient may come back again, and there's high thrombotic situations.
No, I would probably not give aspirin, give ticagrelor and regular anticoagulation.
So probably your case, scare us that next time we have such scenario, we may stop aspirin after 7 days and we may switch on to ticagrelor plus a low dose rivaroxaban. Is it, sir? Can we do that?
No, I have no experience. I have not done it a single time.
You feel more secure with covering both the pathways, because I felt that it was there's no as such you can be feeling bad about your plasty because it was perfect. There is no dissection. Of course, you missed it, but it was not atherosclerotic. It was thrombotic origin of disease, and there is no as such dissections and disease which you have missed. And you're unfortunate, probably.
I mean, in this case, there are a lot of things like when the patient has presented again, the left main ostium which was missed was just the same.
Okay, yes.
A lot of thrombus at the distal portion extending into proximal LAD and proximal circumflex. So whether it was a drug resistance also would be an argument.
So this is an unexplored thing for NOAC, sir. In this scenario where we fear a re-event like in prothrombotic condition, where basically the pathology is thrombus, probably we can use that rivaroxaban. And
actually, that study of rivaroxaban 2.5 twice was not in connection with
thrombus,
angioplasty related thrombus. It was in general to reduce the event rate.
Right.
But I'm not very sure what I'm talking right now. But
and one more
check,
thing,
and next time we'll discuss this 2.5.
One more thing, sir, regarding the size of stent. Now, again, you took 4.5 or you took 4 and you post dilated with 4.5, because now you have to go to LED.
Though that time we took 4.5 because, as I said, I never like to go to, I never like to take 4 to 5 and 5.5. So 4.5 was the
so probably nominal at the LED and you higher pressure at the left main.
Yes, I think when you deploy the stent, you deploy at maybe 6. So the stent is not really stretched to a big diameter in the LAD. Withdraw 2-3 millimeters, go high pressure, and then do bring in another balloon for left main.
Great case, sir. Great. And patient is doing fine now?
Yes. After that, no trouble.
Such a nightmare to have such thing post-plasty, isn't it?
Yeah.
Varsha, Ravinder, you are there?
Yeah.
Any comments?
No. Just to add on to that rivaroxaban, like sir rightly pointed out, that was mainly to prevent peripheral vascular events rather than a coronary event, the role of rivaroxaban. I would have also probably thought of giving a NOAC and a single antiplatelet rather than a dual antiplatelet after facing such a scenario. Of course, imaging would have really clarified the doubt.
Fine, sir. Sir, should we move forward, sir? Should I present my case?
Yeah, please.
Fine. Um, can you see the case, sir? My slides?
Yes, we can see your slide.
Fine. So my case is about a zero contrast angioplasty in a calcific osteal disease with the guidance of IVUS. So the history goes like patient was a 58-year-old male, hypertensive diabetic, known CKD, baseline creatinine was around 2. Presented to a peripheral center with the interval MI before a month back at the time of presentation. He was not thrombolized, and he was managed with usual medications and treatment, and then angio was done outside. We showed a calcified osteal LED disease, but after angio he went into CIN and had a bad LV failure because EF was just 35%. Create rose to 40 milligram percent. He was managed medically with diuretics and inotropic support, and then he took discharge and came to us. He was advised. This was the angio at that time. This was done at a outside other center, and you can see that there's a osteal LED disease, long or around 20 millimeter disease. There's dominant circ, and there's some distal component of the left main as well as also involved. And RCA was very small. It was just a non-significant vessel. So he was advised, both the options was given, but he opted for angioplasty. So we planned for a zero contrast or minimal contrast angioplasty in this case. This was the angio. So we planned that may have to use some cutting balloon or some other modality. IVL was not on shelf because of the cost constraints. So we have cutting balloon as an option, and other thing was like doing a high pressure dilatation with open NC balloon. So first IVOS was done, and after we wired both the vessels, IVOS was done, and then this was the run I wanted to share with you all. You can see there's a fibro calcific disease starting from the mid part, just distal to the LED. This is a diffuse disease, fibrotic, more of fibrotic than thrombotic. And as we go closer, there's a calcium which comes up in from 7 to 10 o'clock position, and some part there was a concentric calcium as well, 360 degree also. As we go more proximal, you can find more diffuse involvement of the calcium here. And as we go towards the left main, distal left main was also involved. Even the mid part of the left main was also involved, around 40 to 50%. This is the circumflex. And as we go back, there's some involvement of the left main as well. And we took a different images. Distal part, this is a proximal part. Just near the ostium, you can see concentric calcium. And even at the ostium, the left main also there was a disease. Took a pullback from circumflex as well, and circumflex was really most area was healthy. There was some plaque in there, but it was not a big disease thing, not more than 30-40% disease. But while pulling back, there was some disease in the left main as well. So you were taking to mind that we have to take care of left main ostium. We have to cover the left main as well. So this is the circumflex. You can see it's almost free of disease, not much disease there. And as we come back inside the left main from the ostium, you can see after this ostium, the left main is also diseased. So we were pretty sure that we have to cover the left main also till the healthy part of the LED. So we marked our different zones of landing zones of the distal LED as well as the ostium of the left main, and you can see that it was not a very big left main to start with. Total length was around 8 to 10 millimeter. So first dilated with 3O balloon, but one mishap happened was that while dilating, because we generally go to very high pressure in such fibrotic calcific lesions, so the balloon broke. The shaft of the balloon broke inside the coronary, and we have to take it out with a gelling of that shaft with the balloon in the catheter. You can see the lower part. We put a 2.75 balloon inside the distal part of the catheter. We gradually go to high pressure and slowly withdraw everything out along with the wires, and we pulled everything outside. And slowly under fluoro we took it outside from the groin LV.
When you pull out the balloon, I mean it's a ruptured balloon, right?
Ruptured balloons. And it's a broken, sir. Shaft was broken at the junction of the plastic and the metal.
Okay.
It was not a ruptured balloon. It was a broken balloon, sir. The balloon broke.
Okay. Shaft
broke, sir. So again we cannulated, and again we start afresh. And this time I thought, and we didn't have the size of on IVA. It was 4 size of the LED. So we don't have we didn't have at that time cutting balloon of more than 3.25. Probably it's not available at the moment of 3.5 or 4. So what I did was I used a cutting effect with 3 wires. I put 3 wires. You can appreciate 3 wires in LED. There is a 1 wire here, other here, and third is here coiled. So we did a balloon dilatation with the cutting effect with 3 wires, starting from the part where the calcium started. This is how we did with the 3.5 NC balloon. Starting from the left main till the disease portion LED. At high pressure we went around 18 to 20. Then we did IVAS again to see how much the cutting was there, and we were happy that it was reasonable to have the cutting effect at the distant parts. Although it was not perfect like we had expected, but we found some cuts inside the distal part of the left main as well as in the proximal part of the LED. So at this point, we thought that we'll go ahead with the stenting, and we chose the length was coming at 2.3 to 21. So we took a 4 into 24 diluting stent starting from the left main, and for left main we put a wire in the sinus, coronary sinus, till the we get an approximate idea that where we have to put it, and we deployed the stent at 14 atmosphere. But you can find there's a waste at the distal part of the stent inside the proximal LED. So we went ahead with a 4O balloon again and did post stenting high pressure dilatation with the NC balloon, and after that we did a kissing as well with a 3.5 into 12 balloon inside the LED and the same 4O balloon inside the 4O balloon in the LED and 3.5 balloon in the LCX, and did the final part with the 4.5 into 8 NC balloon. And after the final IVAS was done, we showed an acceptable result. And just run it. It's not running. Here the stent comes and it is well opposed. There is no much malalignment seen. Of course, there is some calcium you can see at the periphery, but stent is well expanded. And as we come outside the circumflex was also well, the area was well, you can find the figure of 8 at that area. This was the left main. So we were happy with that, and we could find good MLAs around 11 to 14 millimeter till the LED ostium. And finally, we took a shoot also, just to be on the. We were quite curious, and because we don't do very frequently these kind of cases, but the result was quite acceptable, so we ended here. This was my case, which I wanted to show to all of you about zero contrast or minimal contrast, sir.
Very well. I think the end result looks extremely nice. So this was single stent or two stents?
One stent, sir. We did a final kissing balloon dilatation, but only one stent used because Circ was disease free. But to our surprise, I was showed a left main disease also, which we were not expecting on angio. So every IVUS do tells us more about the disease, and it was more fibrocalcific than thrombotic.
Very well done. I think we run into these kind of situations. Like today, I did somebody who had 3.1, 3.5 creatinine. It was not very urgent, but we sort of waited 5-6 days. Creatinine didn't change. So if that case I had done tomorrow, I would have probably done with zero contrast like the way it did.
Yes.
But I used a little bit of contrast today. We ended up doing angioplasty in about 22 cc of contrast. So hopefully it doesn't create any.
Right. Great, sir. Any comments, Varsha? You're there, Ravindra?
Yeah. So I think, I think absolutely well demonstrated case of zero contrast PTCA, right? And I think an often encountered trouble is, especially a lot of our patients are covered by insurance, right? They do insist on a angiographic image, at least 1 or 2 at the end of procedure. So we, despite calling it like instead of zero, we just call it ultra low contrast PCA and end up using 5 to 10 ml.
But this was out of our curiosity. We did. We could have managed without that as well. But we were curious because sometimes because you are not that familiar with zero contrast.
Yeah.
So you want to confirm. We have not left anything. Everything you can't see on IVUS. Like if there's some thrombus, some
no flow.
Yes, no reflow, slow flow. So we wanted to confirm that.
I think we are also ingrained to see the angiographic image rather than.
Yes.
I mean, all that you showed before and the one last picture, they were equivalent.
Last was more satisfying, sir.
Yes, that's what I'm saying.
Yes.
So the last picture was very, very satisfying, very important. I think it's a mindset. We can't go away from contrast, and that's why we keep injecting.
Sir, some people have done with carbon dioxide. Any experience or any your thoughts?
Carbon dioxide is conventionally used below the diaphragm. They do not use it above.
No, I have seen some cases with CO2 pushing inside the cornea as well. I don't know. Sir, your any comments? No idea.
We used to do a lot of carbon dioxide when I was in CMC, especially Dr. George Joseph used to do, but predominantly he also used to say that it's only below the diaphragm. I remember we even did an endovascular aneurysm with CO2, but again, like I said, it was essentially.
Why preferably below diaphragm? Any specific reason?
Basically, you don't want it going to the cerebral circulation.
Oh, right.
Risk of embolism and all.
Mm-hmm. And sir, only Visipack is there, or there's some other dye which we can use if you want to use dye in a low amount?
I mean, it's Visipack is isoosmolar, as I understand, correct?
Yes, sir.
And that's why in kidney cases, we always use Visipack.
Right.
How about any experience with zero contrast OCT with saline or dextran?
Oh, yeah. I mean, dextran we've had, but I don't think the images were great. I mean, unless you're really pushed against the wall, I wouldn't do a dextran porosity.
Is there chances of increased thrombus also with dextran? Some people have reported that is why it's not of much use now. People have preferred half saline, half contrast, or only saline OCTs. Do you feel that way, that dextran is that way not used much frequently?
It produces thrombus?
Thrombus.
I have no idea.
No idea. Fine, fine. I heard somewhere that is why people are not that much geared up to use dextran. Otherwise,
I only felt that a couple of times we tried using dextran, primarily because of renal issues. The images were not as good as.
That's great. Right.
Okay, Dr. Omkar, I think we're coming to an end, or is there something remaining?
No, sir, we are coming to end for this session.
All yours.
So thank you, sir. Indeed, it was a very interesting discussion with 4 cases. So we thank our presenter, Dr. Varsha Kiran. We also thank our second presenter for the day, Dr. Ravindra. And as usual, we thank you, sir, presenting very interesting cases and a series of cases you brought. And I always feel, sir, your keen interest and your continuous guidance are making this program a really, really great success. Thank you. Thank you, Dr. Gaurav, being a part of this program. And thanks. It's a complete circle. You started first session, and now you are moderator today.
Yes.
Complete a circle, and we are really, really very happy, sir. Very happy that it's gaining a lot of what you call as popularity. And thank you so much, Dr. Gaurav Verma, sir. You brought a lot of discussion points today. Sir, today Dr. D. Prabhakar, sir, has extended his proxy, sir. He want me to mention that because of CSI upcoming and he's on organizing, there's a lot of meetings going on, and that's why he couldn't participate today's meeting. So he told me to update you on this, and he shared his proxy, but he will be joining us in the next session, sir. So at the same time, sir, I take an opportunity to wish everyone happy Diwali.
Oh yeah, happy Diwali.
Happy Diwali, sir.
After
Happy
the
Diwali too.
Diwali. So with this note, sir, let us stop here and gather again for the next time with 3-4 more interesting cases and a lot of discussions.
Yes, sir. Thank you, sir.
Thank you.
Thank
Good
you.
night, sir.
Thank you, sir. Good night, sir.
Good night.
Bye, sir. Good night.
Bye.